Hi, everyone, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Kimani Hendricks, Multimedia Communications Coordinator for MS Focus, and today we're joined by Dr. Adam Chaifetz, whose topic is copays, COVID-19, and more, total MS care for 2021, and we will address all questions and comments after the presentation. So Dr. Chaifetz is a board-certified chiropractic neurologist. Since 2008, he has been the program coordinator for the Comprehensive MS Center in the Department of Neurology at the Jacksonville campus of the University of Florida. He manages the program through the interaction with patients, providers, and ancillary staff personnel. He is also a strong advocate for patients and interacts with governmental relations representatives and local federal legislature. Dr. Chaifetz has been in clinical practice since 1987. His expertise has been in a collaborative medical environment. Dr. Chaifetz has run and managed the largest chiropractic practices in Jacksonville. The first chiropractic rehabilitation center director in Jacksonville, Dr. Chaifetz has always been at the epicenter of the collaborative care with his patients. Utilizing medical physicians in practice, his patients have benefited from a thorough, comprehensive approach to healthcare, and we're pleased to have him join us to present this important topic. Dr. Chaifetz, good afternoon. Thank you for being with us, and I'll turn it over to you.
Thank you, Kamani, and thank you everyone for listening in today. Happy holidays to everybody. I wanted to thank the MS Foundation, Deborah Foreman, KESIMPTA, everyone for allowing me to do this. I believe this is the last one that we're going to be doing for the year. I wanted to try to do something that was going to leave people with not only information, but some hope and some plans for 2021, which is only less than 2 weeks away. So the title of my presentation is called The Dog Days of 2020, because we think of the dog days of summer being somewhat miserable and not wonderful. And one would have to agree that this past year, 2020, has been a very difficult year in all regards for everyone. So I want to go ahead and bring information to you from our standpoint. We're a very large MS center, and we have the opportunity to really, really know some of the processes that happen behind the scenes. So it's important to know, and it's also important to recognize that your providers are not only the most important part of your medical care, but their support staff and the people who do things for you to get your medications, get your MRIs approved. A lot of this is very intricate and very difficult. And it takes a lot of people and a team approach to get things done correctly. So my whole goal is for the phone to stop ringing, number one, and for me to give you some insight about some things that we're experiencing right now and what you can literally expect coming into the new year of 2021. So the dog days of MS are not all that bad. They're over for 2020 and we're entering 2021. So let's talk about some things. Why isn't this working? Hold on one second.
If you double click your screen, it should give you
okay, there we go. So the first thing that I'm sure many MS patients have already found out is that a couple of medications have gone generic. And I think in the general world, when we hear about medications going in the generic realm, we think that there's going to be some benefit being in the cost. And what does that mean in the MS world, and how is it going to affect patients that are on these specific medications? Unfortunately, for those who are going through this, they realize it's not as simple as picking up a generic from your pharmacy. What if you can't afford your medications when the insurance company like Blue Cross and Blue Shield or United Healthcare decides that they want to automatically switch your medicine, and you get a call one day for the delivery of your medication and your copay is exorbitant? We're not talking hundreds of dollars, we're talking thousands of dollars. Well, I think you're going to find that most people would not be able to handle that. And so the next best thing is to figure out how we're going to get these medications taken care of. And then the last thing I think that's important to know and understand is the patient responsibility in this process, because without the patient doing their part, none of this can happen. It's an extremely important thing that I want patients to know about. So are generics good? Well, we are of the opinion that if the FDA has approved the generic version of the medication, it meets certain standards for FDA approval. Now, does that mean it always meets the approval standards of the patients? Not necessarily. The reason is the formulations of the generics are not 100% exactly like the brand formulations. So it is possible for patients to have adverse reactions on these generic versions because they're not exact to the brand version that that has been out for years. Now, to give you an idea, for some of you that have been in the MS world for a while, how many of you realize Copaxone? Copaxone came out in 1996. So we have patients that have been on this drug for decades, and they're so afraid of getting off the drug that that they're terrified. They get anxiety because they get this letter in the mail from their insurance company that they're going to be switched to a generic version. The other drug that's involved now is called dimethyl fumarate, or the brand name is Tecfidera. And in this medication, what we are seeing is we're seeing that the pharmacies are automatically pushing patients to switch to the generic, sometimes without their knowledge. And the way they find out about it is when they're given a call for a copayment amount that the patient has never had and is not familiar with. So when we think of generics in the MS world, there's a few things you have to know. If you're a brand new patient and you're just starting one of these medications, it probably is not going to be an issue for you. If you're a patient who's been on these brand medicines, it's going to be very hard to get funding for the brand of either of these medicines because they've gone into a generic format. All right. And let's go in the right direction here. So for both Copaxone and Tecfidera, the company Mylan has been granted the ability to do the generic for both of these drugs. Okay. Now, if a patient has a commercial insurance, let's say they have a Blue Cross plan or they have an Aetna plan or something like that, most of the time, if you're on these brand medications, they're going to push you to the generic version. If a person has TRICARE, which is a governmental insurance, you can pretty much count on the fact that they're going to go to a generic version because of the cost factor. Now, when we talk about cost factor, let me give you an idea of what the difference is. brand Copaxone was about $8,000 to $9,000 a month. The Mylan version of Copaxone is about $1,400 a month. So the savings is considerable when you look at the difference between the brand and the generic. Now, we have had patients that have switched to the generic. We have not had any huge adverse events happen. So we don't really see or have a problem with patients going to the generic if the assistance is given to them and they can afford the drug. It certainly makes no sense for any insurance company to push a patient to a generic version of any drug if they can't afford it. And so the patients who are always caught in the middle of this are going to be the Medicare patients. The Medicare patients do not qualify, or the government patients of TRICARE, or if you have a Medicaid plan, they do not qualify for for some of the programs that the drug companies offer. So with Medicare patients that need assistance for their medicines, they have to go to what's called foundation funding. So what if you can't afford your medication? Well, this reminds me of a patient, and of course they didn't look like this, but they certainly had the attitude of this little guy when they were told that they were going to have to pay only $4,000 for 12 syringes. And naturally, I think I might have been the first person they talked to after they saw the letter. This was the perception that I got when I was talking to them. They were pretty darn angry. And so what do you do if you get a letter in the mail from your insurance company that says your brand drug X, Y, or Z? And the reason I say that is probably in the near future, we're going to see some other medications enter this generic realm. So here's what you have to do. If you get this letter that says that, that you have been switched, whether you wanted to or didn't want to a generic, you need to find out what company makes that drug. In many cases, it's going to be this company, Mylan. Mylan should have a co-payment program which supports what are called commercial plans. So what they would do is they issue either a co-pay card, like a credit card, to the patient, and they utilize this to pay down their co-pay expenses when their pharmacy delivers their medication. Okay, so for instance, I'll give you the one thing that we have to sort out from patients. They call up and they're frantic. My insurance company has told me that I can no longer get my drug. And so they don't know what to do. So it's always a good idea, patients out there, providers, if you're listening in, to have your patient call the company that makes the drug first. Find out if they have any kind of programs to keep you on that drug. If you have to leave the drug for whatever reason and go to that generic, find out who makes the drug, call them immediately and find out what your benefits would be with your specific insurance. So if you have governmental insurance, you're probably not going to have a copay with Medicaid. You may have a small copay with TRICARE. Medicare is going to be the plan that's going to be the biggest problem for most patients. When you think about it, the Medicare population probably has the least expendable income, but they have the harshest rules for patient assistance. It is something I honestly cannot understand why we cannot get this changed legislatively. But like this little crowd here of MS patients, if you were to ask all your MS patients, what is foundation funding? I don't know that every one of them would know. Like, I'll give you an example. Right before this, this presentation, I got a call from a frantic patient because her funding ends December the 31st. She didn't know what to do. Well, I asked her to call the company. Within 15 minutes, she called me back with a directive of what the company had advised her to do to keep her continuing on her medication. So sometimes the office can help, but 100% of the time, the patient has to be involved in the process. So what foundations fund multiple sclerosis medications, and how does foundation funding work? Well, it's very simple. All these companies like Novartis, Biogen, EMD Serono, and you go down the list, they all manufacture products. Most of them have brand name products that do not have any sort of generic competition. So what these companies do is they fund specific foundations, and then they direct their patients to apply to these funds to help with the copays. So for instance, one thing I had to do this morning was get a patient's Tysabri infusions approved so that she could resume her foundation funding on January the 2nd. Her foundation funding was through the HealthWell Foundation. So if these names look familiar to you, many of them have been funded by the company or companies that make multiple sclerosis drugs. So my recommendation is know these foundation sources on your own, even without being advised it, but still inquire with the company who makes your drug, because they have a vested interest in keeping you on the medicine. It does you no good if you have a break from medicine. It does the company no good if you break from medicine. And certainly your provider doesn't want you to break from medicine. So let me review these. The Patient Assistance Network, or the PAN Foundation, is actually a compilation of several different grants. The Assistance Fund used to be funded quite a bit by the Teva Corporation, but since Copaxone has gone generic, they do not fund this any longer. That's not to say that there still isn't funding available. The HealthWell Foundation, what I just mentioned, and then NORD, which is the National Organization for Rare Diseases. Now, folks, it's the end of the year. If you apply now, you're going to find there are no funds. So you have to get on this immediately after the first of the year if you have not been involved in this process before. Those that have been involved in the process realize your foundation funding has to be renewed every year. It's not automatic, and it does require patient, activity to make it happen. So do yourself a favor and know where your foundation funding is, know the amount of your funding, and know their contact. Now, switching medications, all right? in the realm of MS care, there really should not be any reason to switch a patient's medication unless their current medication is failing them. And how do we gauge that? Well, we gauge that by whether a person has relapse activity, whether they have activity that increases lesion activity on MRI, or we see that their mobility or disability is increasing. So if we see any one or a combination of factors of these three things on a patient's medication, it may be a reason to switch medicines. But sometimes patients can be sometimes tricked by these insurance companies into changing medicines because the formulary lists or the lists of the medications every year on these insurances change. So as I was talking about in a previous slide, if you do receive a letter that says your medicine will no longer be covered, you have to go on one of these, you do have the ability to ask for what's called a formulary exception. And that's where the office has to do a special authorization and demonstrate to the company that you've been on the drug, it's been doing its job, and in more cases than not, they're going to continue you on the medicine. But we have patients that have fallen through the cracks. We've had patients that were on the same medicine for many years, and because of this whole generic debacle, they were not able to get assistance for their drug because they have Medicare. And believe it or not, providers have had to switch patients on medications that they were doing well on. I think that is not an optimum way for neurologists and providers to practice MS care. The MS providers, we go through a lot of training to know what to do for these patients. And unfortunately, Blue Cross and United Healthcare and Medicaid and all these plans, they do not. They look at everything strictly as a bottom line cost issue. So if a patient has to be switched to a drug to a different drug because they can't afford the drug they're on, that is an option that unfortunately has to be utilized, but it's not optimum. And most clinicians, I'm sure, would not go that route. Now, if a switch is imminent and you do have to change, and this is where you realize how really stupid insurance companies are, because they really don't gauge what medicine you're on. They look at, again, cost. So you cannot go to a drug that's less effective than the drug you're on. That makes no sense whatsoever. So before you ever consider switching a medicine, you have to discuss this with your provider. Never, and I underline never, let a pharmacy or a third party change your medication without a thorough discussion with your providers on this. This is a very serious thing. And many of the providers that I have worked with and that we have trained here would never willfully switch a patient off their medicine if they're doing well just because an insurance company wants it. And sometimes this is where, the office has to do a little bit of fighting on behalf of the patient for their rights. Okay, so some options aren't positive. You know, you get off a medication, if you're on an infusion medication or you're on an oral medication, you're on a fairly moderate to high efficacy drug. And you really cannot and should not be off of that medicine for a long period of time. Now, what's a long period of time? Well, research indicates, and there are a lot of different empirical studies that show that patients that are off a drug for about 30 days or more can be in really serious jeopardy. So getting off a medication, stopping medication because it's too expensive and you haven't explored your options for affordability, I don't think is a good option. And I really don't want you all to consider that as an option. It can be really bad. So whatever you do, don't stop. Okay, don't stop those medicines, because you can have a relapse off of medications. Now, for some of us who may be joining us, which are fairly new in the MS realm, fairly new diagnosed, relapses can be serious. And if a patient is off a medication, they can relapse. If a patient is on the wrong medication, they can relapse. If a patient develops antibodies to a medication, they can relapse. So a relapse can be a very serious thing. And when you stop medications voluntarily, you could be causing some issues that may never return to normal. Okay. And we see patients that drift on and off of medications. And a lot of times my only contact with them is when they are across the street in our hospital on our neuro unit, and they're having a bunch of testing done, and they're probably on steroids because they have relapsed. And it's usually a very serious thing, and it's an expensive thing. And it's something that you want to try to avoid at all costs. Now, in terms of medications, the oral medications, most of the oral medications and all the infusion medications are very high level medicines. So it's very important to stay on these intervals. In the beginning of the whole COVID crisis, we were getting inundated with questions from patients about whether they should receive their treatments. And I'm going to talk a little bit about that in the future, because everyone wants to know what their risk is with COVID. And the remedy to some of the risk in the infusion arena has been that there has been the allowance of some of these infusions to be done in the home setting. So in some cases, it can minimize the risk of a patient getting not only COVID, but also just the regular flu. And it also helps patients who are mobility compromised to receive treatments. Now, one of the things we realized is that during the COVID crisis, that there were even some of the cancer infusion centers that closed down for COVID and were very unprepared. So we had patients that were thrown off their infusion schedules, not because of their doing, but because there were infusion centers that were unprepared for that. And honestly, our small community infusion centers were the ones that we could count on. Our hospital infusion centers never missed a day. Our staff never missed a single day. And we're totally committed to keeping our patients in a safe environment. So whatever you do, do not voluntarily stop your medications without the advice of your providers. Okay, please be in touch with your provider. If you feel like you want to get off your medicines, you don't feel comfortable with it. In our practice, we have 2 clinical pharmacists in addition to the providers that can teleconference with you, can Zoom conference with you, and can talk about the risks and the medications you're on and the different levels of risk that a person would have given your circumstances. So when faced with a medication change, just make sure that you notice that your drug is not on the formulary and has gone generic. So make sure that your provider's office knows that you've received this. Now, the second thing I want to mention to you is, let's say your pharmacy does change your drug to a generic and you've agreed to it. Please never accept delivery of any drug for the first time without knowing what the cost is. Okay, because there are a lot of things that have to be put in place, like copay assistance, in order for you to have a minimal copay. So never accept delivery until you know the cost. We had a circumstance where a patient accepted delivery and they were charged $7,500. And once you accept delivery, you cannot return these medicines. So I want to warn everybody. Now, depending on the type of insurance, or if you're totally insured, again, you want to contact the manufacturer of the medication to make sure that they don't offer some sort of assistance. There are companies out there that'll work with patients on assistance. It's much less likely with the generic versions because the companies are not funding these foundations that we talked about since the drug is generic. So again, I'm going to tell you that it's been the Medicare patients that we've had the biggest challenge with. Okay, and let me explain to you why we've had the biggest challenge. For the current time, Mylan has the generic for Copaxone. And when we had Medicare patients that had to try to go on their assistance program, they basically wouldn't do it. And they also have a caveat in their program to where the medications, if they do give them to a person, has to be delivered to the provider's office. And that is against our policy. So unfortunately, they've made it almost impossible for a patient to get that drug. So you can see how a person was on brand, shoved to the generic, and then the generic company is not working with them. So this would be an instance to where we probably wouldn't have a choice. That patient would have to be switched to another medicine. All right. Now, if there aren't any questions, I'd like to kind of shift the focus a little bit onto some good news, and that is talking about a couple of the new medications that have come out in 2020. So not everything was bad in 2020. We had 2 new additions to the multiple sclerosis treatment market. The first drug is an oral medication. It's called ZEPOSIA, or ozanimod. And when you see the chemical name and you see the last 3 letters, MOD, what that signifies is that this drug is an immune modulator. And this drug is very similar to the medication Gilenya. And what this drug is it's a sphingosine receptor, and it binds to certain lymphocytes. And what it does is it holds them in the lymph tissue and stops these bad lymphocytes from migrating into circulation and migrating into the central nervous system and attacking the nervous system. So this is an oral drug. It's a pill that's taken once a day. The drug does require a very similar pre-screening profile, which will include an eye exam, blood work, and an EKG. And once the screening is completed, the patient can start the medication, usually without having to do the 6-hour first dose observation of having to stay all day in a clinic and having your blood pressure and vitals taken every hour on the hour. It honestly is a parallel drug. It does have similar effectiveness, and the drug also is on the formulary of some insurances, which means that, at this point it is attainable, being a new drug. The second drug that is a pretty revolutionary drug that is new to the market this year, and again, we'll look at the chemical name in a second. The second drug is called KESIMPTA. And KESIMPTA, or ofatumumab, is a monoclonal antibody. So when you look at the chemical name and you see the last 3 initials, MAB, it denotes that this compound is, in fact, a monoclonal antibody. Now, other monoclonal antibodies that are used in MS include things like Ocrevus, Tysabri, and also rituximab. So KESIMPTA is kind of unique in that it is a monoclonal antibody, but it's a once-a-month injection. So all of these drugs now are pretty much being used for everything in the MS realm except for progressive MS, and that includes clinically isolated, relapsing, remitting, and then a secondary active progressive. Now, are they easy to get? Well, ZEPOSIA is on the formulary on some of them. It's easier to start than the Gilenya because it doesn't require the FDO. And then there is copayment assistance offered for commercial patients. And then the governmental plans, it's really going to depend on Medicare and Medicare Medicaid and TRICARE, whether they're on the formularies. And then Medicare, you would have to apply directly to the company for assistance for ZEPOSIA. Now, as far as the drug KESIMPTA, let's talk a little bit about these 2 drugs and how do you know about the effectiveness of the drug? Well, we know that there are a lot of drugs out there for MS now. We know that there are about 14 or 15 drugs out there. And when you think about it, it would be perfect if we could design a study to where we had a whole bunch of patients and all these drugs were tested against each other. But unfortunately, that's not the way that clinical research works in the MS realm. So each of these drugs were clinically tested against one of the other drugs. And so in the case of ZEPOSIA, the oral drug that we just talked about, ZEPOSIA was tested against beta interferon, which is basically Avonex. Now, most people in the MS realm consider the injectable drugs to be on the lower end of the efficacy scale. So ZEPOSIA was tested against a pretty low efficacy drug. So what that means is that if you're on a different drug other than Avonex, it's really difficult to gauge whether this drug would be better or worse than that drug because it hasn't been tested against it. So this is where your provider's clinical knowledge, clinical acumen, their ability to know the class of the medication, whether it would work for the patient. There's a lot of clinical factors that go into choosing a medication for a patient. But it is good to know what it was tested against, because we like to think that they're being tested against drugs that are in a similar realm. So here we see that ZEPOSIA was tested against Avonex. So the way we look at these drugs is that the injectables have efficacy in about the 30% range. The oral drugs generally have efficacy in about the 50% range. And then the infusible drugs have a tendency to have the highest level of efficacy. Now, again, all of those studies are not widespread. Many of these studies were only done against one agent. So that's how you have to look at research. And that's why it's really difficult to tell a patient how well they're going to do on a drug in general or a new drug, because we see a variance in patients who respond to different drugs. And the field is getting very crowded now. There are a lot of choices out there. So patients have to do their due diligence and do their research to kind of know the different classes of medications and what's out there. But I think for some of us that have been in the MS realm for a while, the interesting thing is that patients for decades were complaining about doing injections, and now the newest drug is an injection. So we're starting to see revisions back to things that worked before. But I'll just say that the reason that the drug is an injection is that it supposedly has the efficacy of an infusible drug. So the drug will save a lot of money for patients who do not have to go to an infusion center and get an infusion. The drug KESIMPTA is priced at $83,000 a year. So for the MS market, that's excellent pricing given the competitors that are in the market. One can do the research on what these agents cost, and you'll see that the cost of these medications across the board is pretty high. Okay, but always remember that the comparator medications that many of the research trials choose are some of the lowest efficacy. It's like they pick a drug that they know they're going to perform well against. All right. The next thing I want to talk about are some updates in the COVID realm. So in 2020, one of the things that our health system was ready for was telemedicine. And we really didn't have any problem or any issue in going to a telemedicine format to our patients, because we had already had the whole process set up ahead of time so that when that occurred, we were able to connect with our patients, I think, as quick as a health system had the ability to do so. So telemedicine has really become a gift in this time of crisis, because it's given providers and staff members the ability to communicate with patients directly without them having to leave their home. So it's convenient from the standpoint of patients don't have to leave. I'll give you a little hint. It has a tendency sometimes to keep providers on time when they know they have to do certain things on an online format. And the good thing is you're not sitting in a room waiting. You're at home in the comfort of your home. Now, some other advantages that are there for telemedicine is not only neurology care, but our physical therapy care has expanded into a telemedicine format. We are able to deliver telemedicine services both medically and through physical therapy in Florida and in South Georgia. We also are able to do telemedicine visits for our primary care providers in the UF system and in many of the specialties, like, for instance, through counseling and psychological services. Now, the only disadvantage is that we don't want patients to become too comfortable with not coming in, because neurology is the practice of hands-on. And your providers, your neurologist, your nurse practitioner, your PA, has to do a hands-on evaluation on you to assess your actual condition. So things like motor examination, cranial nerve function, sensory function, balance, all these things are best done when it's done in an in-person format. So our expectations for 2021 are going to be a continuation of telemedicine, but do expect for your provider to want you to come in for an in-person visit. There may or may not be restrictions in who can come with you, like we currently have at this time for safety. All right, vaccines. We're getting tons of questions of people who asked about vaccines. And this is not a simple question, because the first thing that I think Dr. Thrower pointed out is that none of the vaccines that are currently approved or being approved for COVID have been studied in the MS population. So this is really a conversation you have to have with your provider. In general, we feel that if you do qualify, you should get the vaccine, but there may be medical reasons that you shouldn't receive it, okay? And across the board, we advise our patients for vaccines in general not to receive any live vaccines. So some examples of these would be the shingles or the nasal mist, which is the traditional flu. And then when it comes to the COVID, you really have to have a plan with your neurologist, your primary care doctor. They have to look at your medications, and they have to make that decision with you, okay? So talk to your providers about what's right for you. And maybe we'll get some info, some data out of this in the future as far as what we can expect. Now, fortunately for myself, the UF Health System is one of the sites in Northeast Florida. So our staff has already received vaccinations, and personally myself, I was vaccinated yesterday. So there is a huge push to get the vaccines out to the community as fast as possible. And we're privileged here at UF that we're going to be one of the disseminators in the community to do that. So how does your medication affect your risk of COVID-19? Well, this is where we're going to talk about two different concepts: the concept of immunomodulation versus immunosuppression. Now, most of the early MS drugs, when you think about a decade or more ago, when we only had 4 drugs, all of the injectable drugs were immunomodulators. So what that means is that these are substances that are going to stimulate the immune system to fight against, in this case, an autoimmune condition, multiple sclerosis. We also have monoclonal antibodies and other medicines now that play a role in immunomodulation, which means that they control the way that these bad T cells work, but they don't suppress the T cell count. So it doesn't increase your likelihood of getting things like infections. Now, immunosuppressants, these drugs are a class of drugs that suppress or reduce the body's immune system. So there are some drugs out there that will literally wipe out the immune system in hopes of rebuilding it so that it reproduces T cells that no longer attack the central nervous system. So some examples of immunosuppressant drugs are drugs that are given in organ transplantation for like liver, heart, or kidney. So immunomodulatory and immunosuppressive drugs are all characterized by specific things. So when we talk about immunosuppression, these are drugs that are very specific. So these are like chemotherapy drugs that require a specific dosing, a specific window of treatment, and a very specific dosing schedule. So ask your provider if you don't know what classification your drug falls into. So here are some examples of how these drugs work. Lemtrada. Lemtrada is a monoclonal antibody, and what this drug does is it does bind to specific parts of T and B cells, and it does deplete these cells, and it takes time for the immune system to rebuild these cells. So Lemtrada is one of the treatments that we call a terminal therapy. It's a treatment that is only taken for 2 years. When the patient's done with the treatment, the hopes are that they do not have to be treated again. But this treatment is not for every MS patient because there are risks associated with it, and there is a specific patient profile that has to be met in order for the patient to be a candidate for this drug. Another drug that's very similar in having an immunosuppressive effect is an oral drug that's out. It's also a terminal therapy. It's called Mavenclad. Now, Mavenclad is a drug that's taken for 2 years. It's a pill, and it has a similar effect of rebuilding the immune system. So drugs like this can put patients at higher risk under COVID circumstances. Gilenya and ZEPOSIA are immunosuppressants, but they really work more through immunomodulation. If you look at a blood work of a person on Gilenya or ZEPOSIA, their lymphocyte counts are going to look depressed, but the reason they are is because the lymphocytes are being held in the lymph tissue. That's not true immunosuppression. It's really more immunomodulation. Tecfidera has an effect of decreasing the lymphocyte count, so that can also have an effect on immunosuppression. And then lastly, Rituxan and Ocrevus. These are monoclonal antibodies that are known as anti-CD20 agents, which deplete B cells. So if anybody is on these medications or these medications look familiar, you should have had a discussion with your provider about the risks of these medicines, because the higher the efficacy or the effectiveness of these medicines, the higher the risk. So this is what was found in the ECTRIMS update this year. Dr. Mark Friedman found or mentioned that MS patients who were on these anti-CD20 therapies, they put patients at higher risk for poorer outcomes. Now, is that a given? No. It just means that patients in these categories have to be very diligent and be careful in receiving these drugs. Now, two studies that they did, they compared rituximab, which is a CD20 depleter, to Tecfidera. And what they found was that Rituxan was associated with higher risk of hospitalizations, ICU admissions, and ventilations. When they looked at anti-CD20s versus Tysabri, which is a monoclonal antibody that does not deplete, the same thing happened. The anti-CD20 agents resulted in higher risks of hospitalization, admissions, and ventilation. So, given the mechanism of action, the way these work, they deplete your immune system, it's going to probably put patients at higher risk. And this is the opinion of Dr. Jeffrey Cohn from Cleveland Clinic. So, my advice is, if you're on these high-level medications and you don't feel comfortable, have a discussion with two people, a clinical pharmacist and also your provider, and find out your risks versus your benefits, and be knowledgeable and don't have blinders on. Know what your risk is with your medicines. The immunomodulators are the safer ones. They include all the injectables, Aubagio, ZEPOSIA and Gilenya, and Tysabri. So the immunomodulators are by far probably more plentiful in the field. Okay, now I want to shift to something else. And one of the things that MS providers and MS patients struggle with is fatigue. Since MS patients, approximately, I've heard as high as 80% of MS patients have fatigue, we try to manage them through medications. Now, the medications that are utilized, there are none that are FDA approved for multiple sclerosis fatigue. So, in the study by Johns Hopkins, they looked at 3 common drugs that were prescribed for fatigue. The first one was amantadine, which is an antiviral agent that usually is the first line that providers are going to prescribe because it's the safest. The second drug, modafinil, is Provigil, or its complement would be Nuvigil. Now, these drugs are stimulants, and most insurances will not cover these. Methylphenidate is an ADHD drug. It's a stimulant also. And believe it or not, your providers may have to go to that class of drug if a person tries and fails amantadine, and there are no other options. So do the research on these drugs. Again, these medicines were tested against a placebo, all 3 of them, for fatigue. And what happened was the placebo ranked the highest. So it doesn't leave a lot of confidence in some of the providers' minds that there's one remedy for this problem. So if amantadine works for you, it's a safe antiviral agent. The other two medicines, I would be hesitant to start and try before trying safer alternatives. Now, some of the things that they brought up in this study were literally looking at other ways to improve fatigue that weren't pharmaceutically based. And so one of the things that we know is that if you examine your sleep hygiene by having a sleep study done, many times you can capture a sleep problem that may be the culprit or contributing to your fatigue problem. And so when you examine your sleep hygiene with a sleep study, the end result is if you have a problem, you can get a CPAP, you can increase your quality of sleep, you can increase your sleep hours, which will decrease your fatigue. And then the last thing is we encourage everyone to exercise more, because anybody knows that it's a heck of a lot easier to get to sleep when you're exhausted from doing activity than it is to get to sleep from sitting around all day. So our advice is not always the pharmaceutical realm. Look at your sleep hygiene, do some increased activity, and see if there aren't some other reasons for your fatigue. So what are we going to look forward to in 2021? Well, I can tell you that I'm extremely positive, because just having received the vaccine yesterday, I know that there is hope on the horizon for people to really, really turn this really horrid year around, and we can get back to a more normal circumstance. So you're going to probably be stratified according to your age and a number of different factors. And I'm hoping that these vaccines are going to be rolled out quickly. But most people are not going to, I would say, get the opportunity until early next year, spring. So we are going to have to go ahead and continue what we're doing with our precautions for social distancing. In order for us to get the population into a herd immunity situation, we have to vaccinate about 70% of the population. So think about, it's going to be probably at least half the year before it's going to start to resemble what we would think is even near normal. I honestly don't know if the plexiglass partitions and the masking is going to go away. It may not be a bad thing. In terms of holiday traveling, I can tell you all now, and this is a God's honest truth, because we get dashboard reports every day about how many people are in our hospital. In Jacksonville, there are close to 400 people in the hospital now. Okay, we're nearing levels of what we saw early in the epidemic. So if you have to travel, please be mindful, but we're already seeing spikes from the Thanksgiving traveling situation. So please be mindful about that. Speak to your neurologist and your providers about what's going to work for you based on your medication profiles. Now, what you don't want to do is avoid visits with your providers for a lot of reasons. Number one, we have to get clinical documentation in order to continue your medications. get your MRIs approved, get your physical therapy visits approved, get things done for you. So folks, please make your office visits either virtual, your physical therapy visits can be done. Don't avoid visits, and do not avoid going into the emergency room if you have an emergency. They are the safest places to go. The measures that have been taken in our facility and across our community have been unbelievable. So please never hesitate. I think in 2021, it's going to be part of our lives. And so we want to continue with sound principle hygiene. You don't want to go to big gatherings, even family gatherings. We're going to have to deal with this. I think next year is going to be the best year. We're going to look forward. We're going to be stronger. And my words in closing are for everyone to have hope and promise for the new year, because we've lived through the harshest time in my lifetime and in many of our lifetimes. And I think at this point, all we have is hope and promise for the future. And I thank everybody for listening in today. And I want everybody to have a wonderful holiday, whatever it is that you celebrate. Enjoy your time with your family. And I'll be happy to take any questions if anybody would like.
Thank you, Dr. Chaifetz. We do have a comment from Judy. She sent it via chat. She said, first of all, she loves your dog pictures.
Oh, great.
And she said that the presentation was excellent and thorough, and she thanks you. She says that it is difficult to know how a pharmacy negotiates pricing and why they choose what's on the formulary. Unfortunately, cost and which company is a better negotiator, that of which she says she's in the middle of during COVID. So.
Okay. Well, here's my advice for that. If there's an issue where you feel like you are going to be off of your medicine, I think we've kind of outlined some of the steps that a person can take. And I appreciate so much the comments. And if the foundation would like to make my contact information available, I'm happy to help patients, even if they're not patients of ours, get through this dilemma. Because I'll have to tell you, we have a team and a staff that is unlike any. We have worked together for so long that we honestly feel like we are really on top of our game, but that doesn't mean we know everything and we're infallible. And if I can help anybody get through this, I tried to cover almost every single option that we've been using for patients to get through this, because it's so frustrating, not only from the patient standpoint, but from our standpoint. And I will tell you another thing is the insurance companies purposefully make it impossible. If you saw some of the parameters that they use to get a certain drug approved, it would be like saying, okay, you have to fly to the moon and back in a day and we'll approve it. And so their parameters are impossible and they know that they're not attainable. But at any rate, thank you so much for the question. Any other comments or questions or follow-ups?
I will let our listeners know that if you have not joined us before, there are two ways to ask questions. So you can either do as Judy did, you can type it into the chat box, or if you'd like to speak directly to Dr. Chaifetz, you can always use the participants window and raise
Right.
your hand.
Now,
If you're on a desktop, you would find the raise hand feature in the participants window. But if you're on a mobile device, you would click the screen to pull up the menu, select more, and then hit raise hand. So I don't see anything in the chat box right now, but I actually do have a question. You mentioned immunosuppressants earlier and how they could potentially wipe out your immune system. So would that increase the chances of someone with MS getting COVID because there's really nothing?
Yes, absolutely. So that's what we're talking about. We're talking about, and keep in mind that the drug, for instance, Rituxan 10 years ago was used for some of the most severe MS cases. And so it wasn't a common drug that was used. And so when a patient has like NMO, which is a variant of multiple sclerosis, they don't have a choice. They have to be on that drug. You see what I mean? And so in that case, they have to really have a discussion with their oncologist or neurologist, in our case, because it's MS, because some of those drugs do cause very considerable immunosuppression. So like, for instance, Mavenclad and Cladribine and Lemtrada, the first year, your immune system is going to be significantly compromised because of the actions of what the drug does to the T and B cell. It depletes the heck out of them. So that naturally is going to open a person up for infections of all kinds. And so that's why what we had talked about from the ectrums, that the patients that are at the highest risk are going to be the ones on the anti-CD20 drugs. So that's going to be KESIMPTA, that'll be rituximab, and that'll be Ocrevus.
And I do have another question, if that's
Sure.
Okay. If someone with MS does get COVID, would their MS symptoms progress, or is that only if they stop taking their medication for whatever?
That's a really interesting question, because the best way I can answer it is I would have to talk to my providers, because it's not been a common occurrence. Like we haven't been notified by a slew of patients saying, eek, I got COVID, now I'm worse off, or now I'm better off, or you see what I mean? I don't have really a correlate that I could give you as an experience. Now, a patient who does get COVID, unfortunately, is not going to have a lot of options. I mean, they're stuck with it. So their risk factor obviously is going to depend a lot upon what medicine they're on, right? So their precautions are going to have a lot to do with what they're being treated with.
Okay.
All right?
Yes, I don't see any hand raises and I don't see anything in the chat, so I guess you covered everything that people had questions about. But do you have any final thoughts, Dr. Chaifetz?
Yeah, sure. In closing, what I'd like to say is, if the foundation would like to give my email and or office phone number, if you can put it out there for the participants, or add a slide at the end of this or whatever, I'm fine with answering questions, fielding these issues for people, because our office is on top of this. Not every office is, because they may not treat as much MS as we do.
Right.
So we can maybe offer some assistance and guidance in that regard.
Okay, I am copying and pasting your phone and email address right now, so everybody has it. Just a moment.
And of course, we're not a patient's provider, so we're going to give general advice on things. We can't give medical advice, obviously. We want to make sure that, as I said in the presentation, that patients stay on the drugs that their providers have prescribed for them and want them on.
Well, with that being said, that's all the time we have for now, everybody. If you did miss any part of this conference, I know there were some people who came after you started, but if you missed any part of it, it will be replayed on demand on our MS Focus SoundCloud page, our YouTube channel, the Multiple Sclerosis Foundation, and msfocusradio.org within a few weeks. And as Dr. Chaifetz mentioned earlier, we don't have any more conferences scheduled until we come back from the holidays. So I thank all attendees for participating. And Dr. Chaifetz, this was very informative and we always love having you. So it's good to see you again.
And happy Hanukkah. It's Hanukkah this week. Merry Christmas. Happy Kwanzaa. Happy everything to everybody. Let's enjoy ourselves, enjoy our families. And let's just get ready for 2021. It's going to be awesome. It's going to be a great year.